did this. So if you can say, I know I did this because we have a protocol and I do it 100% of the time, then that's actually defensible in court. That is acceptable testimony and proof to the satisfaction of the legal requirements in this country that you've done the right thing. Now, one of the things about this is that mistakes are allowed, negligence is not. So if you don't do what you should have done, that's neglectful. But if you do the right thing and you just don't happen to pick up the ectopic because it was hiding under some bowel or something, that doesn't mean you did anything wrong. That just means you didn't happen to get that image. And that's okay. We're doing screening tests and we don't hold a pregnancy clinic to the same standard that we do in a hospital when there's a patient presenting with bleeding and pain and looking for an ectopic as opposed to a miscarriage. So this is different. Your patients come in with no symptoms, or in general, you wouldn't be scanning them. If you have a medical director who wants to scan patients who have light bleeding or mild pain, like in my center where I live 10 minutes away, and I can come in and scan the patient myself if I need to, that's acceptable. But that's up to your medical director entirely. And keep remembering that everything you do in your clinic hangs on your medical director's license. And so one of the other reasons for following protocol 100% of the time is you protect your clinic's ability to operate because you protect your director's license. That also goes for the licenses and credentials of the people working in your clinic. So we like to provide as much information to our directors as possible and our ultrasound readers. One of the other keys that's mentioned in this scanning protocol is that everything needs to be labeled. I see a lot of scan images where I can't tell the orientation of the scan. Is it sagittal, transverse? I can't tell where it is. Is it just the uterus? Does it include the adnexa? Does it include something else? And is it right, left, midline? So those things, direction, orientation, location, organ, as far as uterus versus adnexa, for example, those labels need to be on every image. That allows for a clear interpretation of the patient's scan. So very important to do that. Um, this is an example of an ultrasound that we had not too long ago. And you can see it says sagittal. By looking at it, I can tell it's close to the midline because I've done this for 40 years. I can see the bladder, the uterus. I can see a little something behind it, and I've highlighted that in red on that other screen. So you can compare the two. If you look at the uterus on this one, and the uterus is under the yellow arrow, there's the cervix, the endometrium are labeled there in the orange part of the image. The bladder is black on the right side of the screen, but there's something behind the uterus. At this point, I can't tell exactly what that is, but that's enough to say I need more information. So all the time, the most important image that we get in an ultrasound in a pregnancy clinic is the image that ties the cervix directly to a gestational sac. In this case, it's tied to the endometrium, but I don't see a gestational sac inside the uterus. And you can see the muscle around the letter E is the uterine muscle. So I know that that's the uterus. But behind, on the left of that in the image, there's something else, a black space with something in it. That could be stool in the bowel. That could be a lump inside an ovarian cyst, a solid mass. It could be an ectopic pregnancy. So I need more information. So we'll share all these images with you so you can go down image by image by image. And so there is a more, the transverse image on the screen right now doesn't tell me exactly what's what, because is the part on the right uterus, or is the part on the right something else? And is that on the left side, the dark oval, is that an ovary or is that an ectopic pregnancy? I can't tell from this image exactly what I've got. There's no clear point of reference. So that's why having labeling makes a big difference. If I know the sonographer knows to label this as transverse right adnexa so that I know that the gray on the right half of the uterus is, I mean, the right half of the picture is uterine muscle, and I can't tell, is that fluid or a sac or whatever? I need more information. Next image, go ahead. So it turns out that's uterus on the right side of the picture, but I see now a 10-week pregnancy where it's got the not decidua. This is actually the chorion. I labeled this picture, I just used the wrong word. That's labeled correctly farther down. But that's where it says decidua. That's actually the chorion, the placenta and the chorionic sac around the embryo, but the uterus is off to the side. This is a picture of a 10-week ectopic. And this happened to be missed because I think the interpreter thought that we just had a fibroid uterus that was thick on the front side and that the pregnancy was in the back half of the uterus. Not so. So what I suggest you do is at the end of this or sometime look at the images that will come in your email and pull them up side by side so that you can see how this is an example of why you want to look really, really carefully at your scans and say, I'm seeing what I expect to see. I'm not seeing what I expect to see. So, Heidi, if you can go back up toward the top of these pictures, I just want to point out one thing for those who actually do scans. Um, okay. So if you look to the left of the letter CX for cervix, there's actually a small black space there. And that's actually cul-de-sac fluid. So behind the cervix, you have fluid, and behind the cervix, you then have the mass, which is the ectopic pregnancy. So this is the kind of thing that says right off, I'm not seeing what I expect to see. And even if you're not sure you got a pregnancy in the uterus or not, this is the kind of scan where you say, this patient needs to go to the hospital and get this cleared up. So she's going to get the correct discharge instructions and go to the right place. Because the most important thing here is tying the cervix to a gestational sac, which should be in this image where the E is. That's where we have endometrium, but we don't have a sac. And we don't have that in this picture. So the suspicion for ectopic goes way up from image one. This is the correct image one of every scan. This is your midline scan. And where you see the two orange lines heading toward the right, that's actually where the cervix connects to the vagina under the bladder, which is B. This is the right first picture. It just wasn't interpreted correctly because somebody, I think, thought that under the E is a fibroid and the pregnancy is behind it in the uterus. And that's just not true. Okay, we can go off of that. Are there any questions at this point that you could put in a chat to just say, I need to spend a moment on this? Okay. Next thing, I'm going to talk about training. So the questions on the protocol for this session have is a nurse sonographer in a pregnancy clinic part of best practice? Sort of. Best practice is to have an RDMS who is OB credentialed, certified, doing your scans. However, for most pregnancy centers, we just can't do that. It's consistent with American Institute of Ultrasound in Medicine, AIUM, and A1 standards, Association of Women's Health Obstetric and Neonatal Nurses. I have to get A1 right. Um, it is consistent with their standards that a limited ultrasound, and this extends to things like point of care ultrasounds in emergency rooms, is within the scope of practice of a trained nurse. Now, you have to be trained, and someone should review to make sure that we can declare competency. So there is no credential for a nurse in sonography, but an RDMS or a physician trained in OB ultrasound can review a nurse's performance in ultrasound and say, yes, this nurse appears competent. And so we use that term when our sonographers go out and assess nurses. And we recommend that a medical director can review this. And if agreed, the medical director puts in the personnel file for the nurse in your center. Our nurse has been screened and appears competent to perform limited obstetric ultrasound in our pregnancy clinic. And then the medical director signs that. Training for that, we recommend the NIFLA didactic online. We're updating that. A new version of that will be available in the next couple of months. We have the practicums, which give 4 days of intense training. Nurses get to scan approximately 30 models so that they can get some hands-on skills and get some familiarity with how ultrasound machines work if they haven't had a chance to do that prior. Some nurses have already had exposure because you have an RDMS available in your clinic, or a senior nurse has at least given them a chance to see how to do the basic scan. And then you come to a practicum, or if you've done over 100 scans and you think you're already pretty good and you want one of our nurses, one of our RDMSs to come up to your site, we'll spend a day assessing whether or not the nurse now appears competent, and we can put that statement into the personnel file. So training, we recommend as best practice, if you're going to have a nurse sonographer, is didactic to get the basics of understanding the physics, why ultrasound machines work and how they work. That's important to know, at least on the surface, because that allows you to know how to adjust the different image settings on the ultrasound machine to know whether it needs to be brighter, darker, more contrast, different depth. The different reasons for why ultrasound machines work the way they do has everything to do with physics. And so having the basic understanding of that as part of the training. We do recommend ongoing oversight and training. So periodically having an RDMS review a nurse Annually is good if you can do it, that it obviously has a cost to it, but having an RDMS or a doc review a nurse's performance to see whether bad habits have crept up or some other reason that we should consider additional actual training to reinforce good practices, that assessment should be made every year. Now, in my practice, since I review 5 centers, I have a number of different sonographers to keep track of. I actually review the images every time I read a scan. I see, did the nurse follow the protocol we gave? Are they done in the correct order? Do they have the correct clarity? Are the gain settings, the focal settings, the image sizes? So, for example, once you're focusing on a small embryo, you need to enlarge the screen. You need to zoom on it so I can actually see what I'm seeing. So these little things I actually assess every week. And that way I can tell whether my nurse maintains her competence. I would encourage medical directors to adopt that practice. If they don't, bring up an expert. This training protocol that, or actually not training protocol, this the scanning protocol we forwarded actually came from an RDMS who is an instructor at Virginia Commonwealth University in Richmond. So this is someone who knows her stuff. And that's why this protocol is basically bulletproof in terms of defending that you're doing the right thing. So you need to be trained up and skilled at doing this. And every nurse sonographer should memorize that sheet of paper. You can also tape it on the wall next to your ultrasound machine so you can kind of go down and make sure, yep, I did that, I did that, I did that. However you want to do it, but it needs to be followed every single time. Any questions, Heidi? Any comments?
Yeah.
Anything else I need to do?
We do have a couple questions that came in. Going back to the protocol, we had somebody ask, what are your thoughts on scanning transvaginal only? We have RDMS sonographers at our center.
If you have a patient who you expect is very early and you don't expect that you'll get a good scan abdominally, and you have someone skilled, that is acceptable, but it's not exactly optimal. I would say that in terms of recording your images, you may want to do that. But this is where the survey, you don't violate protocol. You do your survey abdominally. And if you see a lot of bowel or you see that the uterus is tiny and you have a patient who, if you say to your patient, you know, you're very early. We're going to get our best images if we just go straight to a vaginal scan. Is that okay with you? And the patient says, sure. Then yeah, you go straight to a vaginal scan for collecting images, but you still follow the protocol. You do the vaginal survey, and then you do the vaginal images, sagittal midline to connect the cervix with the vagina under it, and the I mean this under the bladder, the vagina, and then the cervix next to that, and then you connect it to the gestational sac next to that, that kind of thing. You follow the same protocol every time. You may or may not see bladder on a vaginal scan, but you will see a little point of connective tissue, and that tells you you're still in the right place. So yes, vaginal scans are fine with an expert as the primary screening tool who's made a good judgment as to how to do that. Now, when I say experts, that can be a skilled nurse. I have nurses that work for me that I would trust absolutely that for a limited OB scan, they're going to do the right thing 100% of the time.
Mhm.
And that's because I train them according to the protocol. So they know the protocol.
Mhm.
It's all protocol based. Yes, next question.
Okay. Yeah, we have a couple others here. And yeah, keep putting them in the chat. That's helpful. So question, how soon should scans be read and interpreted?
All medical tests should be read as soon as practical. Now, to me, that means same day. I mean, if you sign on for this, that's your job. Now, if you go to your doctor's office and you get an X-ray and you go home, what's considered standard within a day or two. If it's a Friday, that doesn't mean waiting a day or two business days till Tuesday. So what happens is the longer that time lag, if the patient actually has a problem, such as an ectopic or a miscarriage, and she ends up bleeding for rapidly on a Saturday night because we don't cover call, then you got a problem. And if it's because you didn't read the scan from Wednesday, that's going to reflect badly back on you. So I would recommend to all medical directors that their scans are read as a matter of policy, same day whenever possible, or within 48 hours 100% of the time. So that makes you basically bulletproof from a liability standpoint.
Mhm. Okay. Um, question about policy on allowing, excuse me, allowing clients to hear the heartbeat, especially abortion-minded patients.
Never in the first trimester. There is absolutely no indication for that. There is absolutely no evidence that hearing is better than seeing, because we've all heard the phrase seeing is believing. We've not heard the phrase hearing is believing. Seeing is believing is just as good. It's evidence that the patient knows what's there. And so, and this goes along with standards, national standards from AIUM and A1. You never Doppler in the first trimester over an embryo. That is just considered too high energy, and we just don't do it. The risks are theoretical, but because they are there and they're published, and if there's a problem later on, somebody can point to that as a liability. And so there's no need, so just don't ever do it. Now, can you Doppler the adnexa? If you got an RDMS and she thinks she might have an ectopic and she wants to Doppler that thing, absolutely. But she's not Dopplering the embryo. That she's putting her energy focus on the non-viable tissue. And again, if you have an RDMS who is trying to confirm no heartbeat in a miscarrying patient, and she's done her M mode and it's flat, she does a cine loop just focused on the embryo. I don't ever want to see a cine loop sweep across the entire pelvis, again, because that opens up to questioning by somebody else if it happens to sweep over something quickly, and they're stop actioning. A lawyer's expert witness will stop action that picture every 10th of a second to see what you missed. And we can't do that with every cine loop. So I don't recommend cine loop except on the embryo to look for a heartbeat. And that substitutes for a Doppler. RDMS with skills says, I want the Doppler for proof that there's no blood flow within the gestational sac. I can live with that from an RDMS, not from a nurse. They're not trained specifically in Doppler and should never be trained in Doppler because that's just outside of the scope of practice.
Thanks. Couple other questions. Let me look here. What corrective action was taken for the missed ectopic at 10 weeks?
Remedial education. We can't go back and fix that. As it turns out, in this case, patient presented for care shortly thereafter and got treated successfully. So there's no real problem with that. Um, yes, it was an oops, but fortunately, it wasn't bad. We know of a case in 2024 in California of a similar nature where a mother died. That was a $4.75 million lawsuit. And between the money and the loss of reputation, that center no longer exists. So we don't want pregnancy clinics shut down. More importantly, we don't want to lose mothers. So this is why, if you don't know what you've got, seek help. And I'll get to that in a minute.
Mhm. Okay. Another question, and Lisa, correct me. I think I understand what you're referring to now. Old protocol for scanning, how many images was kind of the standard collection versus this new protocol? How many more are we now collecting?
So in old teaching, it was 6 or 8 images: sagittal uterus, transverse uterus, 3 measurements on the baby, heartbeat, report. So you got 6 images and a report page. Um, but that really doesn't tell you if there's other information that you might want. So, for example, if you take a single sagittal image and you've got twins side by side, you're going to miss them. And that's an oops. That is actually a malpractice oops. So, this is why we recommend multiple planes, multiple levels. We also recommend scanning out into the adnexa, not to find the ectopic, but just to say, is there something big or noticeable there that simply means you're going to forward this patient to care urgently, same day care? And that's just using this. You've got the ultrasound on the belly, in the vagina. Do you see something you don't expect to see? And this is another reason for the in-depth training that we do, because we want the sonographers to identify a loop of bowel versus a mass. Bowel shows
Mhm.
up all the time. It's in the pelvis. You can't avoid it, but you have to know where the bowel stops and something else starts. And so this is why our protocol requires 11 to 13 images every time, abdominally, if you're doing abdominally. And then if you're doing vaginally, another 11 to 13 images. And the reason it's 11 or 13, it depends on how many measurements you take.
Thank
But
you.
your bare minimum is
Mhm.
11. And ideally, it's more like 13,
Mhm.
each location, vaginal and abdomen.
Good.
So
Um, Thanks. A couple more. Leah, I do see your question. I'm going to hold it for now. If anybody else has more questions, put them in the chat. Dr. Matt, a couple of things we wanted to talk about or have you share. So you shared great information about like nurse sonographer training. Can you share a little bit about what training should the medical director receive who is interpreting scans, assuming again that they haven't been doing this in their daily practice in in their
very,
job.
very good. Um, so ideally, you have an obstetrician who either does their own ultrasound or who has been trained to read them as part of their residency training or other training picked up along the way, or an OB certified radiologist. That's gold standard. Now, we do have family docs, general surgeons, orthopedists, even reading scans. But all of these individuals have gone on to get separate training. So NIFLA has an advanced ultrasound course online. It gets a little bit into the weeds, but it does cover the basics well. In addition, what I've been doing since I started with NIFLA is for any doc in that boat, family practice or whatever, emergency room physicians I've dealt with, um, who wants to get into this, I bring them to Fredericksburg and spend an afternoon, a day, whatever is necessary to make sure they understand what they're looking for, when what they report is normal, how they actually type their reports so that the reports say enough and not too much, and all of the little details that go into responsible interpretation and record keeping for the limited obstetric ultrasound.
Okay, thank you.
So that to me is ideal. Um, I don't get to see everybody across the country, but for those who want it, they can have it.
Great. Dr. Matt, a couple other things we wanted for you to touch on if possible. One thing I know in the past when you and I have had some conversations, you had shared about the importance of the nurse sonographer or RDMS, the documentation, not only on the image, but in the report to the doctor. Can you share a little bit about like an example of what would be sufficient so that the nurse and doctor are both understanding the same thing, aside from the labels on the images?
Okay, so the I know with both eKairos and Way Cool, and I have centers on both the clinics, three clinics on eKairos, two on Way Cool. Um, each of them has a section for comments, and so I think if a patient has a normal looking pregnancy, but a nurse wants to say, I have some questions about, the right head exit, whether that's a corpus luteum or something else, a nurse can do that. Um, one of the concerns I have about comments is that either I've seen nurses put in things that are basically diagnosing things, and that's outside of scope of practice, um, or comments that are serious enough that they shouldn't just be thrown in a comment section that may not get read. If it's that serious, that requires a phone call. I don't consider texts or emails sufficient when there's a concern. If there's a concern, it's a phone call. If a doctor has office hours or something and can't pick up the phone immediately, you need to know the doctor's receptionist's number or staff nurse in the office so that a message of concern goes straight to the doctor. And then it's the doctor's liability as to whether they answer that in minutes or at the end of the day or the next day. Ideally, that's answered within minutes if there's a concern. And I usually tell my nurses that if you're that concerned, the patient stays in the office until you get an answer. And if it turns out to be after a half hour, you don't have an answer, you tell the patient, and we'll get into discharge instructions in a minute, um, what they need to do. And, we'll get back to you when we can. Our interpreter is tied up, but and this is why discharge protocols are actually very, very important because they are the best defense you have.
Mhm. Dr. Matt, if you want to go right into discharge, and maybe with that, you can include the last piece about rescans. When are rescans
Absolutely.
appropriate, and how does that combine with your discharge process?
Okay. So rescanning, couple of things. There are do's and there are very clear don'ts under rescanning. With the pregnancy of unknown location, if you do a scan and you can't prove a yolk sac or embryo in the uterus connecting the gestational sac to the cervix, you have a pregnancy of unknown location. That is going to be an ectopic pregnancy roughly 10 or 20% of the time. So that requires additional evaluation. The discharge instructions for that patient have to be clear that she has a choice to make. She came into your center as an asymptomatic patient, typically, no bleeding, no pain other than just the usual menstrual cramping of a growing uterus early in pregnancy. And with that in mind, having a pregnancy of unknown location in an asymptomatic patient is not an emergency that necessarily requires hospital referral. It might, and if a patient wants to go to a hospital and her insurance is going to cover it and all that, that's up to her. However, normally what's involved is you need to get to a provider, a local OB or family doc if they're willing, somebody who is on call, somebody who has a 24/7 follow-up. They can get quantitative blood pregnancy tests. They can get other ultrasound follow-up through another center, another hospital, a different clinic. Or if the patient feels comfortable that maybe she's really only 4.5 weeks and just needs to give it another week or two, and she continues to have no pain, no bleeding, and doesn't feel comfortable going to an emergency room or getting a bunch of blood tests every other day, she can choose to simply see if she's still symptom-free in a week or two. The key thing about the discharge for any patient in your clinic is that she is completely discharged from care. No follow-up appointment is given because you don't want to give the impression of continuity of care. Having an appointment on the books means the patient is still on your books. She is still your patient. And since we don't have call at midnight on a Saturday, that's not something we do. So, very important that patients get completely discharged and have miscarriage and ectopic precautions. If you have a language barrier, you better make sure you have a third-party language line available to make sure the patient gets her instructions correctly. If you have, for example, a Spanish-speaking patient and you have a Spanish speaker in your office, a staff member may interpret, but not a family member or a friend. The reason for that is you don't know what they're saying. They may have a bias and they may want to say something other than what you say. So it has to be somebody unrelated and unknown to the patient. So discharge instructions are critical. They need to, even for our patients where we see viable pregnancies, we give miscarriage and ectopic precautions to them all, 100%, because yes, we have the rare heterotopic pregnancy where even though we see one, there's another one hiding outside the uterus, and anybody can miscarry. So all your patients deserve to have clear discharge instructions for miscarrying and ectopic pregnancies. They can also do things like rupture ovarian cysts and bleed into the pelvis, which still requires surgery. And so if they get the belly pain, the swelling, the dizziness, the bleeding, they should still go to an emergency room. Whether it's a ruptured cyst or a miscarriage or an ectopic, doesn't matter, that they need the clear instructions on what to do if things don't go well. Now, in terms of follow-up appointments, you have basically two reasons. One, you can't confirm all three of the goals of the pregnancy, limited pregnancy ultrasound. You might see a gestational sac in the uterus with a yolk sac, but you can't confirm a heartbeat, or you can't confirm a gestational age. So you've confirmed an intrauterine pregnancy. In that patient, it's reasonable to still give the discharge instructions so you're not on the hook if she develops new symptoms. But if she stays normal and she comes back in a week just to get confirmation that that yolk sac now has grown an embryo next to it, that's okay. Ideally, you discharge her, no appointment. She's still well in a week. She calls back and makes an appointment for that day, next day, and gets seen the following week. But with that information, scheduling a week later appointment is acceptable. The other thing is that sometimes you'll have a patient come in, you can see the pregnancy, she's on the fence about carrying it, or she wants to carry it, and her boyfriend, husband, mother, father doesn't want her to carry it, and they're not there. Bringing her back in a week with the family member who's giving her a hard time, or her husband is out of town and she just wants to share that with him. Psychological support of the mother is an indication for a follow-up ultrasound. So we always have to have an indication for a medical test we do, any test, but that's your indication for a second scan. The other indication for a second scan is abortion pill rescue follow-up. So if a patient gets into the protocol for progesterone therapy, you want to do an initial scan as soon as possible and make sure that she does have a pregnancy that will carry, presumably carry. And then rescanning in a week or 10 days or 2 weeks just to make sure you still have a heartbeat if the initial scan is okay. In someone on progesterone therapy, at least one follow-up scan is reasonable. Some pregnancy clinics do scans every week until 12 weeks. That's overkill. If mifepristone is going to cause an abortion, it's typically you're going to have that result within a week or 10 days. After that, the mifepristone's out of your body. So, if you can do a scan initially and then another scan 10 days or more later, and it's still normal, I would only rescan for symptoms like spotting. So that covers the basic rescan. That covers the basics of discharge summaries. We do them 100% of the time. We do them with language interpretation as necessary. Another thing is a signature by the patient that she understands her discharge instructions, number one. And number two, before she leaves, if she has anywhere she wants these records to go, her portal or to another doctor's office or anywhere else, have her sign a record release. If she doesn't know where she wants them to go, you can always come back. This is not something you do over the phone. She either goes to another office and has them fax a signed release to that office to you, or she comes back, signs her release, and tells you where the records go. Now, as a last thing about records and consents and images and things, I recommend never giving a patient an image with a name or the location of your clinic on it. So if you print out a cute image of the baby, you take a scissors and you cut off the top so that if someone else gets a hold of this image, that they can't put it online and do damage to your patient. It has no identifiers on it. We don't allow any phone recording in our clinics. That it just is bad on so many levels. And there are some states where only one person has to consent in order to do a recording. I don't know about Pennsylvania. I know in Virginia, they don't need the consent of the sonographer to record. But you can simply say, fine, if you have your phone out, I'm not going to record, I'm not going to scan you. And so never allow recordings in the room. Now, if at the end of this, a patient says, I want a video that I can just show my mother, what you do is you close out your exam, open the screen with no identifiers on it, and then allow her to take out her phone. But there have to be no identifiers. That keeps you out of trouble and keeps her out of trouble down the line if things go badly. And unfortunately, we do have things go badly periodically. So I hope that covers all that you need. If we need to do this again, I'm happy to do this again at your discretion. If you need to email me questions, comments, and things down the road, that's fine. I read my email every day. So Heidi, back to you.
Yeah, thanks, Dr. Matt. Yeah, we're about out of time. So those of you that we put questions in the chat and we didn't get to them, I do have them saved here. So following our call, the PLE team will discern what the best way is to get those answers to you, whether it's a direct contact with Dr. Matt or, like we said, maybe a future webinar with addressing some of these things. And then if you have additional questions after the call, feel free to send those our way as well. Again, just so we can see what the need is for possible future webinars. So
Now,
Debbie, go ahead, Matt, Dr. Matt.
um, you are free to share my phone number with those
Okay,
who feel they have an individual question that applies to their center and they don't want to tie up a Zoom call. Um, if it's too much for an email, call me.
wonderful. Thank you, Dr. Matt, for being so helpful and available to us.
Happy to. My pleasure.
So Debbie, I will turn it back to you. I know they're going to offer some prayer, so I will let Debbie explain that piece as well.
Okay, just a reminder for anyone who has not put their email in the chat box, if you can put your email there so that we know some of the names who they're being emailed to. And thank you all for joining us. And if anybody would like prayer, individual prayer, there's a few of us that'll be staying on. It's going to just be 15 minutes. So we hope to be doing this. We would plan to do this again in 2 months. So I hope you enjoyed it, and we will follow up soon with the email to everybody that gave us their email.